Thank you. So I'm going to be taking you through our study on influenza-associated severe acute respiratory infections, SARI, in 5 sentinel sites in Lebanon for the season 2015-2016. So I'm going to be giving an introduction, the methods used, results, discussions, conclusions, and recommendations. To start with an introduction, in the Eastern Mediterranean region, we have scarce data and information on burden of influenza. So in 2014, the Ministry of Public Health Epidemiological Surveillance Unit in Lebanon established a severe acute respiratory infection SARI sentinel surveillance. And after 3 years of collecting data, we were able to have a season and we had the objective of trying to estimate the proportion of influenza-associated SARI among all-cause hospital admissions. The methods used, so it's going to be divided by SARI, so the routine SARI activities, and the study to come up with the influenza-associated numbers. For SARI in general, we have 11 sentinel sites representing Lebanon geographically. We've trained hospital focal points on finding and reporting cases to the Ministry of Health. We use WHO's standardized case definition, which is an acute respiratory infection with fever or history of fever greater than or equal to 38 degrees, cough requiring hospitalizations with symptoms within 10 days. Nasopharyngeal swabs are collected from the cases. The specimens are sent to the National Influenza Center in Beirut, and they're tested for influenza using real-time PCR. The data received is analyzed for descriptive and bivariate analysis. As for the study, we have chosen 5 sentinel sites that represent 5 different provinces. The time frame we used for the data was from the 1st of September 2015 to the 31st of August 2016. And we used the same time frame to collect all-cause hospital admissions numbers. Our statistical analysis was based on WHO's manual for estimating disease burden associated with seasonal influenza. We conducted descriptive analysis for categorical data as frequencies and proportions. We, of course, came up with the proportional contribution of influenza-associated SARI to all sites admissions as a percentage, and it was the total number of influenza-associated SARI divided by the total number of the sites' all-cause hospital admissions. So this is just for your visualization of how the sentinel sites are distributed throughout Lebanon. The ones in red were the sentinel sites chosen for this study. Okay, so for the results, this is just descriptive results. So the total number of reported SARI cases for the 5 sentinel sites was 1,044. 98% were sampled, 14% tested positive, and the majority, 47%, tested positive for influenza B. This is just like an epi curve to show you how the cases were distributed. So in blue bars, you can see the total SARI cases. And you can see a peak towards the beginning of 2016, which was like the first couple of weeks of February. And in orange line, you can see the influenza positive, the percent influenza positive and how it's distributed throughout the season. This is for the types and subtypes of influenza. In blue, over here it shows as dark blue, it's influenza B, and you can see how it's distributed throughout the whole season. We had an increase of H1N1, pandemic H1N1, towards the end of 2015, beginning of 2016, and it was kind of replaced with H3N2 in purple. Now, this is a complicated table, but I just wanted to show you how the demographics are distributed. Over here, we have a high number of reported cases of children less than 5 years of age. Over here, they're lumped together. If you look at the SARI counts, they have the highest percentage and numbers. For the positive influenza, we have high numbers, but the percentage isn't as high as the rest of the age groups. For male to female, we have slightly more reported cases of males. We have 231 chronic conditions, 25 of which were positive for influenza. For deaths, we have 23 throughout the season, but only 1 was tested positive for influenza. Now, for our findings on the overall proportional contribution of influenza-associated SARI to all-cause hospital admissions for the 5 sentinel sites from the 1st of September 2015 to 31st of August 2016 wasn't very high. It was 0.16% with a confidence interval of 0.13 to 0.19. Now, if we cut it down by age groups, we also see that we do have a higher proportional contribution for children less than 5 years of age. And if we take less than 2 and 2 to 4, they're also higher than the rest of the age groups, which is 0.41% altogether. Now, by sentinel sites, this is also a complicated graph, but what I'd like to show you is that one of our sentinel sites, represented as E over here, has the highest proportional contribution of influenza-associated SARI, especially in children less than 2 years of age, which is 4.5% compared to the total, which is 0.16% in general. And taking all less than 14 years of age, they also have high proportions. And this sentinel site is located in the southern province of Lebanon. Distributed by month, we also have a peak of a proportional contribution of influenza-associated SARI in February 2016, which is kind of in line with the epicurve shown at the beginning. To discuss our findings, so we were able to estimate the proportional contribution of influenza-associated SARI in these 5 sentinel sites, and children less than 5 years of age had the highest reported SARI and influenza-associated SARI. A southern province sentinel site has higher reported cases, and these reasons need to be further monitored. Searching the literature, we have comparable results to our neighboring countries, especially when it comes to age group differences. The limitations of the study is that we only took 5 sentinel sites and we have 11 sentinel sites. We weren't able to actually conduct a burden of disease study because we do not have catchment population. And this study relied on SARI, so severe cases needing hospitalization, and didn't take into consideration outpatients, like the ones we can find in influenza, like illness surveillance, which is still being established in Lebanon. So our findings again suggest that we have higher proportional contribution of influenza-associated SARI in children less than 5 years of age, especially in a southern province sentinel site in Lebanon. But despite the lack of catchment population, this is the first step in understanding and indirectly estimating burden of influenza in Lebanon. What do we recommend? We recommend that these findings help prevention programs in Lebanon, especially immunization policies and programs, especially among high-risk population. This study should be repeated to include all sentinel sites and not just the 5, so the 11 sentinel sites. We also recommend testing other agents other than influenza, like for example, respiratory syncytial virus, which might be also a cause of high admissions for children less than 5 years of age. And we also recommend monitoring the reasons behind high admissions in the southern province sentinel sites. I'd like to acknowledge everyone who took part in this, the sentinel sites that took part in reporting and in surveillance, the WHO Eastern Mediterranean regional office and country office, and of course MediPIET supervisors and fellows and the whole team. Thank you.
Thank you so much, Majd, for this comprehensive presentations and being on time and give us a chance to more discussions and more highlighting the issues that you are raised in your system in Lebanon. Actually, one of the recent evaluation by the WHO for Lebanon influenza SARI surveillance system was done, and it was structured with a fully implemented SOPs. Also, it was well operated for the quality of the data and the better use of this data, both in the central and in the peripheral level as well. Now the floor is open for questions or discussions or comments, please.
Konstantin Remish, Moldova. Thank you for a good presentation. Could you explain from these 5 sentinel sites you told about E1, and you said that it is increased. Could you think about and explain a little bit why was the sign such a difference?
Yeah, so we have a theory, but this needs to be tested. So this Sentinel site is located right next to a Palestinian refugee camp, and there might be a form of agreement with the UNRWA that takes care of the refugee camp to admit cases to this Sentinel site, to this hospital. And so this might, and they might have higher delivery rates, so that's something that needs to be tested. So this is our theory for now, that it might be related to its location next to a refugee camp.
Yeah, thank you. Chairman told about the WHO evaluation. So, of course, you use case definition of standardized and the WHO. Yeah, thank you.
Christina Stavridis from Macedonia. I would like to ask you about the laboratory test of SARI case. Do you test it only on influenza or for other respiratory pathogens?
Yeah, so that's the thing so this is just our third year in this influenza surveillance, and it's basically just influenza for types and subtypes of influenza A and B. We still haven't conducted any laboratory tests for other agents, and that's one of our recommendations, to actually test other agents as well.
Roman Rodina from Ukraine. Thank you for this interesting study. I would like to ask you only one question. Did you take into account vaccination status of the patients with SARI? Thank you.
Yeah, so vaccination status is on the form. I don't have the findings with me right here, but in general, they're very, very low, because we don't have any policies that require, there's just recommendations, but not policies. So what I could say right now is that it's low, that's all.
So maybe difference between sentinel sites could be explained by vaccine coverage, or did you study this issue?
Yeah, maybe you're right. I will take that as a recommendation, and we could look that up. Thank you.
Yes, no questions. Actually, Majd, I have a question for you. Are you use this surveillance data, or are you willing to use this surveillance data for determination of the seasonality of the influenza in Lebanon? Are these influenza valuable to give you the seasonality, as you are bringing indirect burden, which is very good results from your surveillance? And also describing the severity of influenza, could you get the benefit from the surveillance data to do this?
For this seasonality, we could, but we just needed more data, because it's true it's been 3 years, but we only have effectively 2 seasons. But I think to have a more complete figure of seasonality, we also need the ILI surveillance, which is being established right now, so we could have a general idea of influenza distribution and seasonality, because for now we're only relying on those cases that are admitted to the hospital and not outpatients as well. So maybe combining both of them, we could find a complete seasonality. For severity, I think there are specific tests to conduct this, but we do have all the information necessary from the SARI surveillance data, and we could come up with a study just on severity. Yes.
Thank you so much, Meg, and thank you for your questions.